So I am so thrilled to introduce you to today's speaker, Dr. Eleonora Teplinsky. She is a medical oncologist who specializes in breast and gynecologic cancers. She is the head of breast and gynecological medical oncology at Valley Mount Sinai Comprehensive Cancer Center in New Jersey. And many of you may be familiar with her because she's very active on Instagram, Dr. Teplinsky. So if you don't follow her, I encourage you to do so. She shares all the time and is so compassionate and educated. It's a great way to stay up to date. She also has a podcast called Interlude Cancer. So I am going to turn it over to Dr. Teplinsky, and I will come back from time to time to ask some of your questions, but just remember, put your questions into the chat.
Okay, hi everyone. Thank you so much, Jean, and the rest of the team for having me. So, the goal of today's talk is, it's a big topic. We're going to talk about some of the newer treatments for both early stage and metastatic. We're going to talk about triple negative, HER2 positive, hormone receptor positive, and it's really a high level overview of what's happened in the last few years, what's happening, what we can see in the future, and how to manage some of the side effects. It's a lot to do in an hour. So please feel free to put any questions in, and we'll try to, answer as many as we can. These are my disclosures. None of them are relevant to today's talk. Okay. So the overview that we're going to touch on really is that the landscape of breast cancer treatment has changed drastically over the last few years. There's changes in treatment paradigms, both in early stage and metastatic breast cancer. And when thinking about how, it would be best to structure this talk, I thought we'd break it down into really 4 classes of medications that have revolutionized how we are treating cancer. So we're going to talk about antibody drug conjugates, immunotherapy, CDK4/6 inhibitors, and some of the novel endocrine therapies that are, some have been approved and some that are being studied. And we'll talk about the mechanisms, the drugs, what they're approved for, and touch on side effects as well. Okay, so let's start with antibody drug conjugates. So there are a lot of medications that fall into this class, and we'll talk about what they are, but this is Enhertu and Kadcyla and Trodelvy, among others. And essentially what they are, it's different than chemotherapy. It's different than what we traditionally think of, as our immunotherapy like Keytruda. These are classes of medications that have 3 components, and you can see that here in the photo. The 3 components are, there is an antibody, there is that's the antibody, then there's a drug, also known as the cytotoxic payload, and then the 2 are linked together via a linker. So what happens is the antibody will bind to a specific protein or receptor that is going to live on certain cells, including our cancer cells. And when that antibody binds to the cell, the linker then activates to cleave the antibody from the drug or from that cytotoxic or cell death payload. And then the drug enters the cell and it can cause cell death. So it's binding to an antibody, but then really injecting something really toxic into that cell. And the benefit of antibody drug conjugates is it essentially spares a lot of the normal cells, so that it's a very targeted cell death. It's more effective, has in general a little bit less toxicity because it's not targeting all of our cells. And some people call it the biological missile for targeted cancer therapy. And I like that because it really speaks to it's very, very focused. Now, a lot of our antibody drug conjugates have what's called a bystander effect. And the idea is that the toxin, it goes into that cancer cell, but it kind of spills out in the tissue surrounding that cancer cell or that targeted region. And so you're kind of bathing the cells around it. And so it's a little bit more effective, but it can also cause more toxicity. So a really simple way that I like to think about it is if you're making jelly donuts and you inject the jelly into the cell, but some of it spills out and kind of gets on the surrounding area. That's kind of what an antibody drug conjugate will do. It'll get inside that cell for that very targeted delivery, but then kind of go on a little bit outside as well. So Enhertu is the big antibody drug conjugate that a lot of people have heard of, and it's used for really the majority of metastatic breast cancer at this point. So Enhertu is also known as trastuzumab deruxtecan, and this is a photo of how it works. It's also known as TDXD. So the T is the trastuzumab. We know as trastuzumab is Herceptin. So what it is that trastuzumab is an antibody that will bind to the HER2 protein, and then the deruxtecan is the drug that goes inside the cell. So the drug binds via the trastuzumab, the linker is cleaved, and then the deruxtecan is released inside the cell. And you can see here, over here, after it causes cell death, you've got that bystander effect where it goes into that neighboring tumor cell. So Enhertu was first approved for HER2 positive disease. And then because of that bystander effect, they realized, well, you don't have to have a lot of HER2, even if you're HER2 low and have a little bit of HER2 expression, because it goes to the neighboring cells, it's very effective. So it was approved for HER2 positive and HER2 low metastatic breast cancer. There's also data for ultra low, where you have just the tiniest amount of HER2 expression, but it's not FDA approved for this indication yet, although people are using it. So in terms of what HER2 low is, prior to this distinction, people would say you're either HER2 negative or you're HER2 positive. And in early stage breast cancer, because we're not using this medication yet, in early stage 1 through 3, we're still really kind of binary, negative or positive. But in metastatic disease, what happened with this study was there became this new classification. So the graphs up here, the photos up here, are what pathologist looks at to determine if something is positive or negative based on the amount of HER2 expression. And if you have no HER2 expression at all, you're negative, although we're now starting to group some of these into an ultra low category. And then if you are 3+, you can see it's a lot of HER2, so you're positive. If you're 2+, it's equivocal. There is a confirmatory test that we do. And if that's negative, or 1+, meaning just a little bit of expression, then you're HER2 low. And when we were able to give Enhertu to this population, we were able to treat a significantly greater number of patients with metastatic disease, which was really amazing. So this study was the Destiny study presented at ASCO back in 2022, I believe it was Destiny Breast 04 trial. And they looked at patients that were HER2 low, and they found that it essentially doubled the time that people were on the medication without experiencing disease progression or dying from breast cancer. And this very quickly became the standard of care in that HER2 low. And so it's really offered up a number of new treatment options for many, many patients that didn't have it before. Now, the other antibody drug conjugates in breast cancer, the other two are Kadcyla, and Kadcyla we use for either HER2 positive metastatic breast cancer, as well as for patients who have early stage HER2 positive disease, who had neoadjuvant therapy, did not have a pathologic complete response. And so rather than continuing Herceptin and Perjeta, we will switch to Kadcyla for a little bit of a different way to target HER2. We have Trodelvy, which is used for metastatic disease, both in triple negative and hormone receptor positive HER2 negative. And all of these have a different target. So for example, Trodelvy, it doesn't bind to HER2 like Kadcyla or Enhertu do, but it binds to the TROP2 protein, which many cancer cells express, and then it delivers SN38, which is a topoisomerase inhibitor. It's a different type of drug. And so these drugs are extremely effective and have really, again, changed how we treat both metastatic and early stage breast cancer in terms of Kadcyla. Now, datopotamab deruxtecan is a novel antibody drug conjugate that is very far advanced in clinical trials and not FDA approved yet, but we're going to wait to see if that happens. There are over 100 different antibody drug conjugates in development, not just for breast cancer, for many different types of cancers. So this is a field that's really, growing quickly. But in breast cancer right now, the majority of the data is in metastatic disease, but we're starting to move some of these drugs in the early stage setting, and I'll show you that a little bit later on. Now, in terms of side effects, the side effects of antibody drug conjugates really are related to that payload. So that's the drug. So again, remember, antibody binds, linker is cleaved, and then the drug gets injected into that cell. And so the side effects are related to that drug. And they vary. They can include low blood counts, neuropathy, hair loss, fatigue, diarrhea, GI toxicities. We see liver enzyme abnormalities. The big one for trastuzumab deruxtecan that we watch very closely is pneumonitis or inflammation of the lungs. And there is about a 12% incidence of that of pneumonitis happening, and we have to follow it closely and stop the treatment and give steroids if we see it. So because there are very serious consequences of pneumonitis. And so different antibody drug conjugates will have different side effect profiles. And improving tolerability and toxicity is important because we get more benefit from that bystander effect, but we also have more toxicity. So, it's a trade-off. So before we move on to the next category, Jean, are there any questions that are coming on ADCs that we can answer?
Yeah, well, first of all, thank you. That slide was so helpful, and I'm seeing in the chat that a lot of people really appreciated it. So one question is, what about dosing? Does everyone start at the highest dose within HER2? How does that work if the side effects are really hard?
I think that's a question that really people are looking into and trying to figure out, does everyone need to start at the highest dose? For now, it's really on an individual basis. I think it's kind of seeing how they're feeling even going onto that drug. I will have some people that I start at the highest dose and other people who are already coming in and their blood counts are, maybe they've been on a prior treatment where their blood counts are low or they already have, some underlying GI toxicity. So I may start them at a, medium dose. So there's not really a one size fits all. I think it's having that discussion with your doctor about, can we talk about the dose that we're starting at? Are we starting at the highest dose? If so, I'm concerned about, these side effects. How are we going to manage it? But there's not really, for now, the standard starting dose is 5.4 milligrams per kilogram. So it's based on your weight. But again, some people may start at a lower dose, and that really is that individual discussion. And the same thing goes for our other antibody drug conjugates.
Yeah, so that's helpful. So for everybody listening, this is important, talk to your doctor about the dosing. And then it's also important, now that we know about HER2 low and ultra low, that your biomarkers get retested. If you want to talk a little bit about that.
Yeah, so ultra, we'll take that out of it just for 1 second. For
Okay.
HER2 low, you actually don't need to get retested because it's already going to be on your pathology report. So the pathology reports, and now both for early stage and metastatic, are going to describe that HER2. So they're going to say, is it 1+? Is it 2+? And then based on that, your doctor said, oh, you're positive or negative. And so now you can actually, just by looking at your pathology report and going to that slide I showed you with the 0, 1, 2, 3+, you can actually say, oh, I'm HER2 low. Now, ultra low does need to be relooked at because these are ones that are being scored as 0 because there's really very little expression. And so this does require the pathologist to take a look. And I will have called the pathologist and said, is there any HER2 expression? I know you said it was 0, but was there any signal at all? And so that does need to be relooked at.
Great. So I'm going to ask 2 more questions together and then you can move on. One is, there are questions, will Enhertu be available in early stage? And do that one and I'll find the second one.
Great question. So like any drug, every drug always starts in the metastatic setting for a number of reasons, but also we are able to more, gives you efficacy a little bit faster because people have active disease and we can see did it respond or not. There are clinical trials of moving Enhertu into the early stage setting. They are ongoing. So a lot of that depends on how quickly that those studies accrue and what the results of them are. So we'll see. Sometimes things that work in the metastatic setting don't work in the early stage setting. We'll see that a little bit later on, but I don't have any information one way or another at this point.
Okay, I'm going to let you keep going. Thank you.
All right. So let's move on to immunotherapy. Immunotherapy, has been around for a while now. We use it in so many different cancers, but we really started using it in triple negative breast cancer about 3-4 years ago now, longer if you were on a clinical trial. And I have this slide here so that you can look back and you can kind of really that you can kind of read this in more detail. But the idea with immunotherapy is that normally cancer cells are able to evade the immune system. So the immune system does not recognize your cancer cells as foreign. And so the immune system doesn't attack them. When you get sick, when you get a virus, your body is able to say, hey, this virus doesn't belong in the body, and it attacks it and gets rid of it. It doesn't do the same thing for our cancer cells until you give immunotherapy. Also, these drugs are called immune checkpoint inhibitors. And what these are is they essentially stimulate the immune system to attack the cancer. So they stimulate the anti-tumor immune response. And the way they do that is by releasing the brakes that typically keep the immune system away. And so it stimulates that immune response and it promotes the immune system to eliminate the tumor cells. Very effective, but what can happen is sometimes the immune system gets excited. And so then it can activate our normal T cells, which can attack and cause basically almost what is like an autoimmune disease. It kind of stimulates your own T cells to attack different organs. And we'll talk about some of the side effects in a second, but so really immunotherapy has 100%, if nothing else, revolutionized cancer outcomes. We use it in so many different tumor types, but let's talk about how we use it in breast cancer. The drug that many people may have heard of, been familiar with, is Keytruda or pembrolizumab. Again, approved in many cancer types. In breast cancer, it is approved in 2 areas right now. The first is for metastatic triple negative breast cancer that is PD-L1 positive. And these are biomarkers that will predict response to immunotherapy because of the way that the drugs target. And it's immunotherapy in combination with chemotherapy. That's the Keynote 355 trial. And then the Keynote 522 trial in stage 2 to 3, early stage 2 to 3 triple negative breast cancer in addition to chemotherapy. Now, I can give you a whole talk for an hour on the Keynote 522 study, but the idea is that immunotherapy very quickly became standard of care for stage 2 to 3 triple negative disease because of a significant improvement in outcomes. And actually just last week or 2 weeks ago at the ESMO meeting in Barcelona, they presented 5-year overall survival data and for the Keynote 522 study. And 5 years is a really important marker, especially in triple negative disease. And what they showed was that people who received immunotherapy, 5% more were alive at the 5-year mark than people who did not receive immunotherapy. So nearly 87% of patients were alive at 5 years. Now, we want to be at 100%. We're not there yet. We want to be more than 5 years. But this is still very important milestone for this drug in this disease. You do not need to be PD-L1 positive in early stage breast cancer. That's something that comes up a lot. And we are starting to see there's some good trials in hormone receptor positive, HER2 negative. This is the Keynote 756 trial. And so we're waiting that data. We know that when we gave immunotherapy, kind of similar to 522, but in hormone receptor positive, more patients had a pathologic complete response, meaning at the time of surgery, more people had their cancer go away. but we don't know yet if that actually translates to a lower risk of recurrence and a lower risk of dying from cancer. So that's what we're waiting for before it gets approved and before we start using it routinely. But, we're making progress. Now, in terms of the side effects, so I mentioned that the T cells get activated, you get all these things that kind of seem like are autoimmune diseases. The most common thing we see with immunotherapy is thyroid. You should be, if you're on immunotherapy, you're getting your thyroid levels checked very regularly. But it really can affect any organ system. It can affect your brain. It can affect your heart. It can affect your intestines, your muscles, your joints, your bones, your kidneys, your lungs, your liver. And so we're constantly monitoring. And a challenge is people will say, well, how do I know if a side effect is from immunotherapy or if it's from chemotherapy? And I will say sometimes it is hard to tell. But, I always tell people, let's say you've been on, you've had 8 weeks of chemotherapy and you've had no side effects. And now all of a sudden, you start having a ton of diarrhea. We want to make sure that that's not inflammation of the intestines from the Keytruda. Sometimes you can't tell. And sometimes if we can't tell, we treat it with steroids. And if it gets better, then that can be a really helpful sign that it was immunotherapy related. All right, Jean, any immunotherapy questions before we move on?
Yeah, I do have an immunotherapy question, and then I think I have a few more ADC questions.
All right.
So someone's asking if this person already has a history of autoimmune disease, is immunotherapy more likely to trigger an overreaction of an immune response?
It depends on what that immune disease is and how well controlled it is or not. So, a lot of people already have thyroid issues. That really isn't a contraindication to treating with immunotherapy. But if you're really, let's say, uncontrolled, some sort of autoimmune, like, maybe even like an uncontrolled lupus where it's flaring and then that may be a situation where we may not even give immunotherapy. So these are individual discussions. I will say that we've gotten a little bit, as immunotherapy has become much more commonly used, we've gotten more comfortable with using it. And so years ago, we may not have used it at all. And now we're trying to test and see, all right, can we give it? Can we monitor it closely in conjunction with all of the other doctors that are caring for your immune diseases? And I will say that this is where, especially for immunotherapy, we're working with all of our other specialists is so important because we're going to use the cardiologist if you have myocarditis or inflammation of the heart. We're going to use the GI doctor, the rheumatologist. So we're working with all of our specialists here.
Got it. And so for the side effects from Keytruda, do they lessen over time?
Yeah, so on a day-to-day basis, most people don't really have many immunotherapy side effects. I will say some people feel like occasionally a little bit nauseous, but day-to-day, you really don't have it. But when you have an immunotherapy related event, it's going to kind of comes out. So, and then we treat that. We usually will treat that with steroids. So it's not something where you have it every time. Those we don't want that to worsen, so we're going to treat them at really the earliest point.
Okay. And if you're doing well on Keytruda, it's working. Is there a length of, can you be on it for as long as?
So in the metastatic disease, yes. I mean, typically, I will say usually around 2 years. We typically don't continue for more than 2 years, but there are, of course, exceptions. And then in the early stage setting, right now, it's 1 year of Keytruda. It's 8 cycles with chemotherapy before surgery and then 9 cycles after.
Okay. And then this is a question about PD-L1. If their numbers are dropping, so I guess they're having less PD-L1, and they have triple negative breast cancer, should they still stay on immunotherapy? I don't know if they're metastatic or early stage from
Remember, PD-L1 only matters for metastatic.
Okay.
It's typically a once, we don't really usually keep rechecking it. So as long as the immunotherapy is working, we would continue it.
Okay, so I want to ask just one ADC question. I'm not going to do a great job pronouncing the new drug that's in the pipeline, Dado
is good.
Dato's good. So can you just share, is this, what subtype is this looking at? And, do you have a sense of when it might?
Yeah, there's a number, they're looking definitely at it. It's being looked at in a couple of different disease breast cancer disease types. It's furthest along in right now, I believe, in the hormone receptor positive, but there are some triple negative studies as well. I do not have an idea of when it will be approved. That those decisions, live with the FDA, so I don't know.
Got it. All right, I'm going to let you keep going.
Okay, so what I wanted to share is just some ongoing trials for early stage triple negative breast cancer. And so the idea has been, well, if someone has a pathologic complete response with immunotherapy and with chemotherapy for triple negative breast cancer, we know that a pathologic complete response is important. And so if you have that, do you really need to continue the Keytruda after surgery? And so the Optimize PCR study is looking at actually taking away Keytruda, de-escalating for people who have a pathologic complete response after neoadjuvant chemotherapy and immunotherapy. So participants on that study are randomized to either receive no treatment or pembrolizumab. Now, the Optimize RD study is the opposite. If you do not have a complete response, well, yes, we want to continue the Keytruda, but can we do something else? Obviously some cells were resistant, and so we want to kind of optimize our treatment to try to make sure if there are any residual cells that we can see that we get rid of them. And their Optimize RD is just one of the several escalation studies that are out there. Without a study, people who don't have a pathologic complete response are typically either some will get pembrolizumab alone, some will get pembrolizumab plus Xeloda, which is an oral chemotherapy, and those who have a BRCA mutation will get olaparib, a PARP inhibitor. And the studies are looking at novel drugs. And so the Optimize RD study is looking at sacituzumab govitecan, which is Trodelvy. That's an antibody drug conjugate we mentioned earlier. So here we are now moving it into the earlier stage setting. And other studies are looking at different ADCs and different targets. And I think these are really important studies because this is how we're going to get better outcomes. We're going to start getting, we want to get close to 100% of patients without a recurrence. And so the more we can tweak and pivot and individualize therapies, the better. So now let's switch gears a little bit to CDK4/6 inhibitors. Now, these are drugs that are used in hormone receptor positive HER2 negative breast cancer. There is some data for using them for HER2 positive in the metastatic setting, but not FDA approved. So we're not going to touch on that. Those are smaller studies in very individual situations. So approved metastatic and early stage. So again, I have this photo up here, so you have that idea of what they do. Bottom line is that the CDK4/6 inhibitors prevent cancer cell growth. They prevent cancer cell proliferation. And the way that they do that is by interfering with the cell cycle. So on the right over here, you see a picture of the cell cycle. So there's growth, the S phase is DNA synthesis, G2 is more growth, and then mitosis, and they split into two. So for all of our cells, including cancer cells in the body, they have to grow, and then they basically replicate into two, and that's how more cells are made. And so the CDK4/6 inhibitors block a key component of that transition between G1 and S in the cell cycle. And they do that by suppressing this phosphorylation of the retinoblastoma tumor suppressor protein. It's a lot to say, but the idea is you need, in order for cells to go through the cell cycle, you need phosphorylation of this RB protein, and the cells block that process. And so cancer cells can't replicate and they die. So in the metastatic setting, we have 3 drugs that are approved: palbociclib, which is Ibrance, ribociclib Kisqali, and abemaciclib Verzenio. In the early stage setting, we have 2 drugs that are approved. I'm going to focus more on the early stage because that's a little bit newer. The drugs in the metastatic setting have been around for a long time. We do know that we're seeing a little bit less use of Ibrance in the metastatic setting because some studies have come out saying that maybe Kisqali is better, but Ibrance is still very often used, and then we can pivot from switching from one to another if we need to. But let's talk about the early stage. So Verzenio, or abemaciclib, has been around for longer. It is approved on the basis of the Monarchy trial. This study, it's approved for patients who either have, so all hormone receptor positive, HER2 negative, they have to have 4 or more lymph nodes, or you could have had 1 to 3 lymph nodes and then either had grade 3 disease or a tumor size greater than 5 centimeters. Initially, when it was approved, it was also approved based on a Ki-67 value, and that actually has been removed from the qualification to get Verzenio or not. And we've seen the study's been published several times, and they keep publishing longer follow-up, which is great because we know that these cancers can recur 5, 10, 15, 20 years down the road. So the longer follow-up we have, the better. So they've recently published a 5-year follow-up, and they found that patients who received abemaciclib with endocrine therapy compared to those who received endocrine therapy alone had a 7.6% absolute improvement, meaning 7.6% more of patients were alive without a recurrence at the 5-year mark. So you can see in this graph, the bottom line in the blue is the people who got endocrine therapy alone. So that's at 76% were alive without a recurrence at 5 years, compared to 83.6% people who got Verzenio. And what's interesting about this is that if you look, the benefit increases as each year passes. So there's more of a benefit as you go later on, again, because we know these cancers can recur kind of later down the road. Now, Verzenio is not the easiest drug to take. Some of the side effects include diarrhea. That's really the biggest one. There's also fatigue, low blood counts. With the diarrhea, people can have nausea, abdominal pain, there's joint pain. And what's difficult about this drug is that even 1 or 2 episodes of diarrhea can really negatively impact someone's quality of life. And this is where many people require a dose reduction. And there was a study actually published just a few months ago that said, which was so reassuring, that if we dose reduce, we are not compromising the efficacy of the medication. And that's huge because one of the questions people ask me all the time is, well, if I lower the drug because I'm having side effects, am I going to lose its effectiveness? And we have clear data to show that it does not do that. So that's abemaciclib. Just last week, so this is hot off the press, ribociclib was approved also in early stage breast cancer. And this is on the basis of the NATALY trial. So the NATALY trial, same idea in terms of endocrine therapy alone here, just with an aromatase inhibitor, or adding ribociclib to that aromatase inhibitor. Now, the approval for ribociclib, and I have it here, is broader than that for abemaciclib. Abemaciclib is a very high risk population, meaning people at really kind of what we think is the highest risk of a recurrence. And again, within that, there's variation. Ribociclib allowed, if you were lymph node positive at all, you were able to go on the study. So you didn't need all those other things. If you were lymph node negative, then I have that here, you had to have grade 3 disease or grade 2, and there's all these characteristics. But the idea is that it allows for a broader population. And we have data, it was originally presented in June of 2023. And at that point, they said if you add ribociclib, you have about a 3% benefit in reducing risk of recurrence or death from breast cancer. And just last week, they presented the 4-year updated data. And similarly, that 3% jumped to 5%. So we're starting to see that, again, that longer benefit as time goes on. And the big thing here is that it allows patients that are lymph node negative. So based on studies, it's estimated that double the amount of patients will qualify for ribociclib than qualify for abemaciclib. And so this is a really important medication. It gives a lot more options to people, but as always, it comes with side effects. Some of the most common side effects are low blood counts. We have to monitor the blood counts closely. Joint pain, nausea, headaches, fatigue. I will say that ribociclib is a little bit easier to tolerate than abemaciclib. It does require EKG monitoring for the first several visits because it can cause arrhythmias, and we really want to monitor the liver enzymes. Now, Verzenio is given for 2 years with endocrine therapy. ribociclib is given for 3 years. And so, it's a discussion because it's 3 years of more intense visits and more intense following and more intense side effects. And so these are all, really risk benefit discussions with patients and their doctors. The nice thing about ribociclib is that the dose approved in early stage is slower than the dose approved in the metastatic setting. So I think we'll even see some better tolerability, which is really important. And so before we move on to the next group of medications, let's stop here for any questions.
Yeah, we do have some questions. So one is, one person is asking if Kisqali has an interaction with the approved medication for menopausal symptoms, Veozah.
Not that we know of. One of
Okay.
the things that I did not mention is that ribociclib cannot be given with tamoxifen. Okay, can only be given with an aromatase inhibitor. There is an interaction there. I will say with any medication, you always want to check and have your doctor, and I will say, I do this all the time. When I'm seeing patients, I've got my drug interaction calculator up and I'm always confirming and checking because there's so many drugs out there. So we do want to check with ribociclib. We want to make sure with certain drugs that there is no metabolism interaction. There's certain foods. So definitely talk to your doctor about just making sure that everything is okay.
Okay. And then in the metastatic setting, if you started on Ibrance and the cancer has progressed, can you move on to another CDK4/6?
Yes, there are studies that look at I believe the Maintain study and the Post Monarch study. And so they do look at CDK after CDK, and that is an option. What we want to do, and I know you have a whole separate talk on this, is molecular testing of the tumor because we want to see, are there other mutations we can target, different medications. So, but yes, you absolutely can give another CDK4/6 inhibitor if you've previously been on one.
Okay, and then in the early stage setting, there's a lot of questions if the efficacy for Verzenio is still good at a lower dose. Why are so many people being put on the higher dose? And how do you have that conversation up front?
So it's a great question. And so the best thing I can tell you is that the study looked at the efficacy for people who had to dose reduce based on side effects. We don't have a study looking at starting everyone on a lower dose. And so we don't know if that efficacy is going to be the same. Dose reducing for symptoms versus starting everyone on the same dose is a little bit of, starting everyone on a lower dose is a different question. And so I have that conversation. I explain that to patients. And I will say, I have some patients that I know they had a hard time on, let's say, chemotherapy. They're prone to diarrhea. We're not starting at the full dose. On the other hand, I have some people who do great on that full dose and other people who go right away down to the lowest dose. So everyone is different. And I think that while, we're seeing our patients so often, I will change it. I think the key is to be upfront about your symptoms and not to say, oh, I've got 3 episodes of diarrhea. I can handle it. Yes, you can handle it, but do you have to, right? Maybe your quality of life would be better with one or none. So I think it's that conversation. But you're right, that's a common question that comes up and we just don't have that answer.
Right. So it's so important to have a great relationship with your doctor. And if you don't, get a second opinion. I'm assuming this question's coming from a metastatic patient. If a medication stops working and the cancer progresses, can you ever go back to that medication at some point in time?
Yeah, I mean, it depends on what the situation was. I will say sometimes we've re-challenged after a while back, but a lot of it depends on how, what was the progression? How long were you on it? What happened to the disease at that point? How did you tolerate it? So it's really, again, not a blanket statement one way or another.
Okay. All right. I'm going to let you keep going.
All right. So we're going to move on to our last category here, which is novel endocrine therapies. And this graphic makes my head hurt, but the idea is to show you that there are so many next generation endocrine therapies being developed, both for early stage and metastatic. And this is really great because what we have right now, and I'll tell you about a new one that's been approved, but everyone's either on an early stage, they're on tamoxifen or they're on aromatase inhibitors, and the side effects are really profound for many people. People are in a very low estrogen state, and they're living with those toxicities, and they're really debilitating for many people. Additionally, we know that people do develop disease recurrence despite being on these medications. So there's really been a need for agents that overcome these mechanisms of resistance, that still are able to target the endocrine receptor so that we don't have to switch to chemotherapy, but overcome that resistance and hopefully improve some of the toxicity and the side effects. So there's many in development. They all focus on really targeting the estrogen receptor. So SERMs are things like tamoxifen that don't get rid of estrogen in the body, but modulate the receptor. Then we have SERDs. This is fulvestrant or Faslodex. There was a new one approved recently, elacestrant, which I'll talk about. These degrade the receptor. And then there's Protac and Serons and Circas, which all modulate the receptors in different ways. But what's the nice things that they're doing is they're not degrading estrogen. So toxicity, we hope, is going to be less of the side effects that come from that low estrogen state. And there are many, many in development. Every study review article that you look at, it's a table page or two long of all of the novel endocrine therapies in development. And I think this is a field that's really going to explode, hopefully, in the next few years. Now, elacestrant, the trade name for this is Orserdu. This is a oral SERD, so this degrades the receptor, so it doesn't get rid of estrogen, it just degrades the receptor, and it's an oral medication, which is always a good option. And this was approved in January 2023 for postmenopausal women or men with hormone receptor positive metastatic breast cancer who had previously been on at least one prior endocrine therapy, and they all had to have had a CDK4/6 inhibitor, and you had to have an ESR1 mutation. Now, ESR1 mutations tend to tell us that patients may be resistant to aromatase inhibitors, and we're not using ESR1 mutations yet in early stage, but they are really important in the metastatic setting. And so this is why molecular testing is important. Now, ESR1 mutations can arise at any time. So when someone develops disease progression, we're always checking to see, okay, has an ESR1 mutation developed? And this medication, the oral elacestrant, reduced the risk of disease progression or death from breast cancer by about 30%, but then by about 45% in patients with an ESR1 mutation. So it was approved for that cohort with ESR1 because that's where the benefit is the greatest. Side effects are there. Mostly what I have seen is nausea, fatigue, vomiting, and some other GI side effects as well, as you can see here, headaches, hot flashes. The big one that we monitor is lipids or cholesterol. We monitor as a baseline and then throughout treatment, because these, here's where the lipids can go up very quickly on this medication. So this is where, working with your doctor or maybe a cardiologist is important. And I will tell you what I do in the clinic is if I think someone's going to start on that medication soon, I'm already checking their lipids. I'm sending them to the cardiologist to kind of optimize everything before we even start the medication, if that's possible. Now, these are really two trials I'm very excited about in early stage breast cancer. So these are SERD, these are the selective estrogen receptor degrader trials. So we're not blocking estrogen, we're getting rid of the receptor. And so we're moving these drugs from metastatic studies to early stage. So the one on the left is the Cambria 2 trial. This is looking, instead of endocrine therapy, this is for patients who have a high risk of recurrence. You can see on the left the criteria. They're going to get the SERD camizestrant, and they might get, if they qualify, they would get abemaciclib as well. Now, this study was approved and started before ribociclib got approved. Sometimes they amend the studies to allow ribociclib. I don't know what's going to happen here. But in any case, so endocrine therapy or camizestrant. On the other hand, the EMBER-4 trial is a different SERD called imlunestrant, and this is for patients who already had 2 to 5 years of endocrine therapy, and have a higher risk of recurrence, and they're going to be switched to either continue for 5 more years of endocrine therapy or switch to 5 years of the imlunestrant. So again, the reason that these are patients at a higher risk of recurrence is we're hoping that these novel medications kind of, again, circumvent some of the mechanisms of resistance to aromatase inhibitors. But it'll also be really interesting to see what we see in terms of toxicities and side effects. And hopefully the side effects will be better, but only time will tell for that. So in conclusion, then I'm happy to answer questions. Breast cancer treatments, as you can see, really are rapidly evolving. We have so many innovative therapies, and we've changed our treatment options. We're improving outcomes, but we still need to really focus on managing side effects, improving tolerability, so that we can maximize the benefits of these therapies. Because if we have these medications, but people can't tolerate them or their quality of life is impacted, then I don't think we're getting the most out of them that we can. And of course, continued research and clinical trials are essential for the future and for expanding options for all of our patients. And I think we have 10 minutes, so I'm happy to answer as many questions as we can.
You did an amazing job. I was like, you've timed it perfectly. A question I have is, with all these new developments, which are so exciting, and I think SERDs and PROTACs, really, there's so many comments about the side effects of AIs, and we've known that for a long time. Do you feel like this is being pushed out throughout the country to everybody, even people who are seeing a general oncologist, not necessarily an oncologist that specializes in breast cancer?
I think that's a great question. I think it depends on, the trials are not open everywhere. So I think it depends on if the trial is open by you. And I think that kind of speaks on a greater level to the need to make sure that we have trials in the community, right? So often trials are limited to bigger centers, and it's impossible for patients to get there, and the parking, and it's a 3-hour drive, right? So I think it really speaks to the importance of, we need to get patients these trials in the community. I think it's variable depending on where in the country you are and if that study is open. And I will say, we don't know, how, the goal is to test the effectiveness of these medications. So we don't know, this is a trial. We still don't have the answer of how effective is it going to be. And that's what these trials are attempting to answer. So there's always, of course, some hesitation and questions being asked. I would tell you, I get questions all the time. People reach out to me and say, I've been approached about Cambria or Ember. What should I do? And I think the answer is, we really just, these are questions we need to answer.
Okay, and Cami and TrueCap are the same. Is that right?
No.
Okay.
Camizestrant is not. TrueCap is capivasertib, which is a drug with fulvestrant for metastatic patients who have a PIK3CA, AKT, or PTEN mutation. So Capi, that's Cami, different. I don't think camizestrant has a brand name yet, but I could be wrong.
Okay. Why is the GI system so impacted by these CDK4/6 inhibitors?
I think that's just sometimes where the targets are. We know that it can also impact the blood counts. Those are just cells that have those markers and that are a little bit more affected by the CDK4/6 inhibitors based on how they target. Because I think the challenge for any drug is that they target both our normal cells and our cancer cells, right? And so if the normal cells have that receptor, they're going to kind of target those as well. And I do think the drugs are all different. Ribociclib does not have as much of the GI toxicity that abemaciclib has. Ribociclib, we tend to see more liver enzyme elevations. We tend to see more lower blood counts than we see with abema. So they are slightly different drugs because they're all CDK4/6 inhibitors, but they target different. One does more CDK4, CDK6. They all have slightly different targets.
Thank you. And then we get this question a lot. There are some people asking, what is metastatic breast cancer? If you have involvement in your axillary nodes, is that considered metastatic?
Great question. And so it's not. Metastatic breast cancer is breast cancer that has spread outside of the breast and the axilla or the armpit. Where this comes up often is that the pathology report will say metastatic to the axilla. And right? So of course you're thinking, oh my gosh, do I have metastatic breast cancer? But metastatic just means when they say metastatic to the axilla, it means it's spread to the axilla, but that's not metastatic breast cancer. Metastatic breast cancer, one more time, is cancer that's outside of the breast and outside of the axilla.
Right. Thank you. And then what about long-term side effects? I know we think about this a lot, but this person specifically asking about long-term side effects of Herceptin and Perjeta.
Yeah, I mean, I think that's a really great question. Now, we know that Herceptin and Perjeta can't affect the heart. That is typically a temporary and reversible side effect. So while you're on any HER2 based therapy, you're getting an ultrasound or an echocardiogram of your heart on a regular basis. Typically for Herceptin and Perjeta, we do that every 3 months. And the reason that they can affect the heart is that there are HER2 receptors on your heart. So the Herceptin not only binds to the cancer cells, but it can also bind to those HER2 receptors on your heart muscle or on the heart. And so, but that is a typically reversible toxicity. So we're looking at your ejection fraction, which think of this as how effectively your heart pumps out blood to the rest of the body. If your ejection fraction drops or you develop symptoms of heart failure, shortness of breath, swelling of the legs, we interrupt the Herceptin and Perjeta. We hold it typically for about a month and we repeat the echocardiogram. And the majority of the time, that is a reversible side effect. So typically, we don't really see that long-term cardiotoxicity from Herceptin and Perjeta. It's more what we see while you're actually getting the medication.
Okay, that's helpful. This is an early stage question. When do you think some of these new endocrine therapies that would replace tamoxifen or AIs might be available?
I think we're a while away,
Okay.
I think we get excited because the trials are really exciting, but this is the challenge with early stage trials. They are looking to accrue thousands of patients. So number one, you have to accrue these patients, and that takes time. It's different than in a metastatic trial where maybe you've got 200, 300 patients. It's easier to accrue. So lots of patients, number one. Number two, you have to wait to see if there's going to be a benefit. So for example, you have to show that less people have a recurrence, on the newer medication, depending on what their outcomes are. So to give you an idea, the Verzenio studies really started on say 2016, 2017, and it wasn't approved. I think it was approved 22. So it's at least, I mean, it's a couple of years. Same thing, Natalie was a study ongoing 2017, 2018, just got approved, ribociclib. So I think we're at least 5, 6 years away. I would love to be completely wrong, but I don't think it's something that's going to happen in the next, 2 to 3 years.
And if people are interested in learning more about these trials and maybe joining, what do you suggest they do?
So one is talk to your oncologist. The other way to really, take charge and advocate for yourself is go to clinicaltrials.gov. Now you can also just search Cambria 2 and Ember 4 and it'll give you kind of where they're accruing. But on clinicaltrials.gov, it's not the best, easiest website to navigate, but you can put where you're located, you can put your disease type and see what's out there. And so you can type in Ember 4, because that may be if you're already on endocrine therapy, Ember 4 may be the better trial for you. And you could see where it's open and reach out to that facility.
Great. I'm going to ask one more question and then we're going to have to stop. But this person has asked a couple of times. So they want to understand what are the side effects from starting Lupron injections?
Well, Lupron is going to think of Lupron essentially is putting you into menopause. It is, I like to think of it as a switch. It's turning your ovaries off. And the way it's doing that is by kind of certainly tricking your body into thinking that it's making too much estrogen. And so your ovaries should shut down as a result of that. And I have a lot of videos on my Instagram about Lupron that you can check out. So Lupron puts you into menopause. And so the side effects that come are typically menopausal side effects if you're not already in menopause. Hot flashes, joint pain, vaginal dryness, mood changes. Now, it doesn't mean that everyone on Lupron is going to get those side effects, but these are things that may happen. And we do have really good ways to manage these side effects.
Thank you so much. We could probably ask Dr. Teplinsky questions all day, but the good news is you can find her on Instagram and Can you tell everybody your Instagram handle?
Yes, it's Dr. Teplinsky, super easy. You just type in my name and it's there. And I have a ton of stuff on there. I do a ton of Q&As. If you have a question, most likely I have a video or something on it already.
That's amazing. And it's just so great that you make yourself so accessible. And this was a wonderful session. So I want to thank you for your time. I'm sure you probably have to get back to the clinic. I'm sorry.